I'm actually a senior medical oncologist at OncoCare now. I actually trained out of the Cambridge University where I did my ME PhD program as a clinician scientist, and also set up the translational sarcoma and rare cancer program out of National Cancer Centre Singapore, where I'm still a visiting consultant. I actually lead 2 labs in Asst at IMCB and Bioinformatics Institute, and I'm a professor at Duke NUS Medical School. And my special interest is in sarcomas, but I treat other rare cancers, including skin cancers, lymphomas, and now even general cancers out of private oncology in OncoCare Cancer Center. So I've actually sent quite a few samples now, even outside of sarcoma, and even some of them in the potential first-line setting as well. So that's an interesting question that whoever it was who raised that question. So soft tissue sarcomas, this is really a area that, as you know, tends not to do very well in terms of clinical outcomes. So very rare, just 1% of all adult malignancies. But if you look at the younger population, they actually account for a good 20%, in the pediatric and young adult population. And you can see the age distributions here as well. So it tends to be of a younger age group, okay? And then typically, they don't survive very long. First-line treatment response rates, so this is unacceptable, right? So first-line treatment response rates in other cancers you expect much higher, but here we're seeing less than 20%, okay? Nevertheless, it's a big problem because if you look at the market evaluation, this is, in the USA alone, it actually accounts for a lot of healthcare cost, okay? With a CAGR of actually quite a high percentage if you look across the projected CAGR over the years, okay? And then, okay, it's a bit of a lag. And the important thing is that, over the several decades of everyone sequencing, sarcomas almost to the death, okay, to be fair, this is mainly short read sequencing rather than long read sequencing, but there are very few actionable alterations, apart for the typical GIST, and maybe some epithelioid cancers, you don't really see actionable alterations. So even though we use some of these alterations to diagnose the subtype, often they're not targetable, right? So that's a big problem as well. So I think JJ's already mentioned, and everybody already knows what functional precision oncology is, so I don't want to labor this point too much, but just to say that we're not the only ones using this approach, and this has been tried and validated across many, many different labs, many, many different publications. I think it started off really with some of the, pediatric type cancers, but this is broadly applicable to most things now, okay? And that's simply, asking the question, if you got a patient's tumor cell, put the drug on the tumor cell, does it kill it or not, right? Simply that question. Okay, so then we asked, when we first started, working together with Ed and with Dean and with JJ and with Sharon as well, who was our, PhD student, we asked in our own hands, do we see functional precision oncology working in the tumors that we test, okay? So this is an example of a patient with a hepatic embryonal sarcoma. Sorry, it's a little bit small. So these were early days where we tried to use IC50s. We hadn't worked out how we're going to show with IC50s. So all we did was line them up according to a plot. And you can see that the patient's IC50 was a lot lower compared to what is average amongst the published database. And you'll find that, interestingly, when we treated the patient, this is a sarcoma, so we sometimes don't expect very good responses. Nevertheless, we saw improvement. So you can see this went to this, which is actually pretty remarkable in sarcoma, I would say, okay? And then at the bottom, this is another example of a very rare type of sarcoma. It's actually a skin adnexal tumor called a Porocarcinoma. So it came from the sweat gland of a lady, okay? And you can see her lungs are studded with metastasis. So when she saw me in clinic, she couldn't actually complete a full sentence. When I was trying to ask her, what are her symptoms, how she feels. She came in on a wheelchair. She had, high dose supplemental oxygen, and she couldn't even speak properly because her lungs were studded with tumor, right? And of course, no one in the world knows how to treat metastatic skin porocarcinoma, right? If you look up the literature, there's just 3 case reports, all reporting about how various chemos never worked. Okay, so what do we do for this poor lady, right? And she wants treatment. She obviously needs some kind of symptomatic relief as well, okay? So what we did was we said, can we get access to tissue? So in fact, we poked this particular sample here. So we took about 10 core biopsies, and we had enough sample to run it for ex vivo drug testing. So again, this was early days, and we just simply asked the question, how many drugs can we test, okay? And with whatever cells that we managed to get, we tested a whole panel of drugs, okay? And you'll see that, so what I did here was to say, can we line up this patient's IC50, okay, according to what we know of other skin cancers, of other sarcomas that's published in the known databases, and where does this patient stand, okay? So her sample is the pink dot, and you'll see that here with pazopanib, okay, she falls far to the left, okay, so maybe this could be a good candidate, okay? There's another drug here, it's a bit small, I think it's ifosfamide, okay? And there's, there's another one here, I think, is it doxorubicin? Yeah, it's up here. So a little bit more to the left. But obviously, because she was so unwell, we were a bit afraid to give her chemo, and it might just tip her over. Her performance status is quite borderline. So I chose to give her pazopanib. And of course, lo and behold, you see these responses. So as you know, when you use, pazopanib or anti-angiogenic agents, you sometimes see sort of like eating out of the tumors from inside out. So you see this kind of pattern of response radiologically. And what was striking was she came to my clinic. She actually walked off of the wheelchair. She walked 1 kilometer from the train station at Outram MRT to come to my clinic, and she could tell me her symptoms, her story, and complete her sentences off oxygen. So that clinical response was amazing to see. Okay, so we were very encouraged, and of course we published this now, as the very first case report to say for the first time anybody has found something that works, in metastatic porocarcinoma. Okay, so we contributed to that case reports as well. First line, yeah. So that was pretty amazing to see. So then we asked, since we had some encouraging responses, right, do we see clinical correlation across more cases? Okay, and then I think someone asked the question at the start, are there good systemic therapies for sarcoma? What can we use today? That's a similar question we asked 6 years ago. Is there a combination treatment effective for soft tissue sarcoma, right? So we're really looking into this, and of course the three of us started working together, as well as the various people in our lab who, very grateful to, a whole bunch of very enthusiastic young people. And so what we did was we used, at the time, QPOP, okay, on dissociated patient samples that we got across sarcomas out of the National Cancer Center, okay? So, of course, what we did was we took biopsies or resections, we dissociated this in the lab, and then we chose, at that time, this panel of drugs, so it was a combination of some chemo, some epigenetic agents, and some targeted drugs that we thought, might have some signal in sarcoma. And then, of course, we subjected it to drug testing, QPOP analysis, and we generated patient-specific reports, okay? This work is now published out of MPJ Precision Oncology. Very happy to report. And so this is what we did. I think JJ mentioned it before, and our very talented PhD student Sharon, who's working with Kyan at the moment as well. So we collected, this is a fairly sizable number for sarcomas, okay? We collected 51 samples, and a good 48 of them were successful for QPOP, so actually not very many were excluded, okay? And in fact, a lot of them had a good Z-factor score, so I think that's a correlative score, and we generated QPOP reports for about 45 of them. And you can see that there's a whole range of treatment responses in the patients that we evaluated. Importantly, concordance was pretty good. So I think JJ mentioned earlier as well, accuracy value of 76.9%, so nearly 80%. But of course, bear in mind this is retrospective, okay? So the limitations with retrospective as well. But this was pretty encouraging to see for sarcomas, I must say. Okay, so this is really to kind of answer the question of, is there, novel, effective combination treatment in soft tissue sarcoma? So what we did was we looked across, all the different combinations that can be generated out of QPOP, okay? And we found that, hey, there are some novel drug combinations, okay? In fact, the standard of care, so this 13.3% is really doxo and ifos. So that standard of care doxo ifos, it only ranked top in about 13%. Okay? On the contrary, you see much more frequency, higher frequency, where it's top ranked in other combinations. Most of the time it's pazopanib-based combination, but the very top rank was pazopanib and a BET inhibitor. Okay, so we thought that was interesting. So BET is bromodomain extraterminal, I don't even know what it stands for anymore, but
sorry,
yeah.
The meaning of 30.
This one?
And 67 and 7 and 0.8%.
So of the Yeah, of the 45 samples tested, okay, 13% of them were top ranked for doxo-ifos combination, and 67% top ranked for pazopanib BET-I combination.
What's the meaning of rank?
So you know how when we generate the QPOP results, right? You line up all your drug combinations according to which ones kill the cells more effectively, from 1 to all the way down. So these are the ones that showed up as number 1. Yeah? Okay, good. Thanks for the question. Sorry, it's a bit of a lag, the slides. Okay, so Sharon wanted to say how actually if you look at standard of care, you can see that the mean normalized cell viability across all the samples, you can see it tends to be much higher, okay, so maybe not as effective cell kill ex vivo. Okay, but if you look at all the pazopanib, combinations, the top-ranked QPOP combinations, you tend to see, the pazopanib BET-I, for example, highlighted here, the NCV tends to range lower. Okay, so better cell kill. Okay, with this combination. Okay. Yeah, it's not moving. Okay, there we go. Okay. And then, of course, we wanted to ask the question of, why is it this combination is good? Okay, is it just the fact that the two drugs, when you add them together, 1 + 1 = 2, and that's why you get more killing? Or is it the fact that there's actually some synergism where 1 + 1 = to more than 2, maybe 1 + 1 = 5? Okay, so this is where Sharon did these plots basically to look at the shape of the curves. Okay, and you can see that with doxorubicin ifosfamide, they tend not to be synergistic. Okay, whereas with pazopanib BET-I, the shape of the curve suggests that 1 + 1 is not equals to 2, 1 + 1 = to more than 2. Okay. And then there are, again, separate specific tests that you can do to test for whether there's synergy or addition or antagonism even. Okay, so you can see here that ifos and doxorubicin tends not so much to see synergy, whereas anything below this dotted line is more likely to suggest synergy, and we see that more with the BET inhibitor and with pazopanib. Okay, sorry, I don't want to get too technical here, but just to sort of give everybody a quick overview. Yeah, let me know if it's okay. Yeah. So we all know what pazopanib is. I think those of us who treat sarcoma, we all know what it is. It's a small molecule inhibitor of multiple TKIs, including some of the androgenic pathways as well. So this is the pellet trial, out of Winnet van der Graaf's study. And you'll know that there's improvement in median PFS, but not OS, okay, so not overall survival. But it is FDA approved for many advanced sarcoma patients who have received prior chemotherapy. This is how it works, okay. And then this is the compound that became top ranked when we did this work, that synergized together with pazopanib. So it's really a BET-I inhibitor. Specifically, it's the BRD4 inhibitor, okay? And it actually binds active promoter regions and super enhancer regions in dedifferentiated LPS, okay? So very strong BET dependency. Okay, so this is actually an area of active investigation, and it potentially may emerge as a new drug in the treatment of sarcomas. And then, of course, we wanted to ask, does this also work in an animal model, right? So we actually took cells from, D-diff liposarcoma cell lines, implanted it in the mouse, okay, got it growing quite well. And you can see that as the controls grow, if you were to apply either single drug, it doesn't work very well, but if you give them both together, the tumor volume decreases significantly, right? So you see that with the combo, yeah, not so much with single drug, but very nicely shown with the combo, okay? And then this is just to say, what we see when we actually stained these tumors, and you can see that again, there tends to be a lot less. Here we're looking for MYC, okay? So we think that one of the ways in which this combination works is through targeting the MYC oncogene. Okay, so this is a case study. I think we wanted to kind of focus on some of the more clinical types evaluation again. And again, this was early days. So you'll see that, this was how we initially, showed our results. And it's obviously, our Optim.AI reports are now quite different, but this was, how we showed it with early days. And you can see that doxorubicin here, okay, is more to the left, so with an NCV of kind of close-ish to 0.5, okay. Gemcitabine, docetaxel, not so good, okay, but the combo Gemtex pretty okay, pazopanib pretty okay. And sure enough, in the patient, when we went back to, the radiological scans, you see that correlation as well. So you have, I think the arrows are a bit shifted, but this basically showed PR to doxorubicin, okay? And then with Gemtex, there was some minor PR and stable disease, okay, and PR to pazopanib, okay? So we highlighted in the paper some of the case studies as well that were, out of the 45 that we tested, basically, okay? This was another interesting case. So this is solitary fibrous tumor, okay? So this lady, she's a young lady who actually first saw me when she was expecting her first child. Okay, but with all the treatments that we gave her to extend, her overall survival, her child is now 6 years old. So she's actually, way lived beyond her prognosis. So very happy to say that she's done well. Okay, so what happened was she actually had a very rare. Okay, initially it was a brain solitary fibrous tumor that was only localized to the brain. Okay, so she had it operated. She was being seen by the radiation oncologist. She had adjuvant RT. She wasn't given any systemic treatment. Okay, but she was being seen by her neurologist. And what happened was, when her neurologist examined her tummy, she felt a big abdominal mass. And that was when I was called to say, oh my goodness, what's going on, And of course, when we scanned her, we found a huge liver metastasis. It was like the size of a football, literally, okay, nearly 10 centimeters in size, okay. And so that was her first metastasis. She developed liver metastasis. And later on, subsequently, she also developed a local recurrence to the brain at the initial site, okay. So what happened with this lady was that, I gave her, at that time, the standard of care, of course, is, doxorubicin-based treatment. So I gave her liposomal doxorubicin for 2 cycles. But what happened is you can see that it clearly wasn't responding. In fact, it was progressing through liposomal doxorubicin. Went from 8.9 to 9.5, okay? And her being a young lady, she's always asking, what more can I do? I want to live for my girl, right? So we said, okay, can we think about whether we can do a palliative resection of her dominant liver metastasis? Because at the time we're also thinking, what about tumor rupture? How can we prevent catastrophic complications? So we use that opportunity with access to sample to also do QPOP. Okay, and we'll go on to show, what we saw with QPOP later on, okay? And based on QPOP results, actually, I thought, it would argue for the fact we should be giving her pazopanib, okay, which I did give to her, okay? Later on, we needed to enhance her response with, specific local treatment as well. So I did send her for Y90 radioembolization to the rest of her liver lesions, okay? And then she had a little bit of pain in one of her sacroiliac joints from some bone metastasis, so we did radiate that as well. So as you can see, sarcoma is a very sort of multidisciplinary, use multimodal type treatments to manage our patients, yeah? Okay, and then because later on she had recurrence in the brain, local recurrence. Okay, we actually thought this was a good enough sort of time frame from the time she last had her last operation in the brain to this time point. We said, okay, she's fit and young, it's resectable. Let's go in and do a craniotomy for her. Okay, and then of course what we did was we used the opportunity again to send this for QPOP, to get some information about the tumor. Okay. And then later on, I gave her pazopanib and eribulin. And you'll see why, okay? Because this was what we found out of QPOP, okay? So her initial liver metastasis, when she then had that abdominal mass, we cut it out. And, pazopanib was here compared to some of the other drugs, right? So eribulin, doxorubicin, and we can see why she was progressing on doxorubicin because obviously, the NCV was very close to 1, okay? And a lot of these things are some even higher than 1. Okay, so we gave her pazopanib, and lo and behold, she responded, okay, in the liver metastasis, okay. What was interesting is that while she was on pazopanib, she actually had a recurrence of her brain lesion, okay. So, in fact, that's also interesting to see because when we cut out her brain lesion, look at where pazopanib sits. So, it's not surprising that she was progressing past pazopanib because the NCV is quite close to 1, okay. And at the same time, because of this, we thought, okay, of all these things, eribulin maybe has a bit of a chance. So we gave her eribulin, and sorry to say, it's a bit hard to see, but you can see that, so with her recurrent brain lesion, she had 2 lesions quite close to each other. One of it was taken out, the other was too close to critical structure to be removed, so that was left behind, okay? But we did give her some eribulin as well, and you can see that there's some response. So I think it went from, I don't see the number here, but I think it went from 4.9 to, I think, 3 point something. So it did shrink in size as well with eribulin. But again, I didn't expect a huge shrinkage given the NCV wasn't quite so low, but she did respond.